Hi, this is Dawn Altman. Today we're going to talk about determining capture with transcutaneous pacemakers. Transcutaneous pacing is underutilized. I think one of the reasons is it can be very difficult sometimes to determine whether there's capture. Some people are afraid to raise the MA enough to obtain capture, and if they feel they're not having success with the pacemaker, they're very quick to just turn it off or stop using it. Failure to capture and false capture can be real problems, and they can cause people to give up on pacing too soon. To avoid failure to capture and false capture, start with good electrode placement and good skin contact. This chart shows two different electrode placements. A lot of people choose the second one, the anterior apex placement, because it's easier. You don't have to get to the patient's back. But most clinicians feel that the anterior-posterior placement actually gives better contact and has better results with pacing and with defibrillation. For anterior-posterior placement, be sure to place the electrodes to the left of the sternum and spine and not on top of the bones. You want to sandwich the heart between the two. For anterior apex placement, try to get the heart between the pads by putting the posterior pad or the apex pad on the patient's side. Skin contact is crucial. The skin must be clean and dry and free of hair. Clean and dry with a 4x4 or a washcloth, even roughing up the skin a little bit. If necessary, dampen the cloth with normal saline. Shave the hair if you need to. You've probably seen this page from the ACLS book. It makes transcutaneous pacing look so easy. The first strip shows a sinus bradycardia. The second strip shows the beginning of pacing, and they're pacing according to the caption below threshold at 35 milliamps. Almost nobody can be paced at 35 milliamps. So there's a pacer spike, and there's the patient's intrinsic beat, which did not come from the pacer. So this pacer is failing to pace, and the reason is the MA has not been turned up high enough. It can easily be remedied by turning up the MA, the milliamps. In the third strip, you see the pacing spike right there, the stimulus, and now we're getting capture. And this QRS looks way different from the patient's normal QRSs in the strip above. This QRS is wide and pointing downward, and it has a nice visible T wave, and the T wave is also wide and it points opposite the QRS. You'll find that in most wide complex rhythms, the T wave goes opposite the QRS. The fact that there's a T wave is proof that that's a real QRS and now we have capture. Now don't expect capture at 60 milliamps very often. Don't be afraid to go up 10 more at a time to 70, 80, 90, 100. You may need to go over 100 quite a bit before you finally get capture. Don't give up. You might be afraid to go higher on your milliamps because you're afraid it will hurt the patient. Yeah, it can be painful. You may need to medicate the patient for pain, but remember, the consequences of poor perfusion are a lot worse than the consequences of pain. Also, don't be afraid to touch the patient during pacing. You won't get shocked, and it doesn't matter how high the milliamps are. It's safe to touch the patient. This ECG shows false capture, which is an artifact produced by the pacemaker that can resemble a QRS complex. Some of them even look more like QRS complexes than these do. How do I know they're not real QRS complexes? Well, the main reason is there's no T wave after them. Why does this happen? Well, it happens because when you pace the chest wall in transcutaneous pacing, there would be a huge artifact from all that skeletal muscle being paced, and that artifact would take your line or your picture right off the page, and it would be a real mess. So the machine, the monitor, is programmed to close its eyes for a moment for just 40 milliseconds, which is one small block, and it closes its eyes and doesn't look at the ECG. Sometimes when it opens its eyes, it sees the remnants of that artifact coming down back to the baseline. So there's a 40 millisecond blink after each pacer stimulus, and during that time, the monitor isn't seeing what's going on. But when it opens its eyes after the blink, it sees the remnants of that artifact. Another reason I know this isn't a QRS is that the patient's own beats, and there's one right here, I'll show you, the patient's intrinsic beats happen right in what would be the refractory period if that was a QRS. If that was a paced QRS complex, there would be a refractory period where no other stimulus could cause a QRS, but yet here is one. So I know that that pacer never depolarized the heart. Now, some people will see a rhythm like this with the pacer artifact and feel that they're getting a pulse from the patient. There are several reasons for this. One is that you probably will get a pulse from the patient's intrinsic beats, so if they have enough of them, you'll feel pulses with those. Another is that as we pace the chest wall, the body jumps a little bit and it may be perceived as a pulse, especially if you're feeling brachial or carotid pulses. Some of it may also just be wishful thinking. We're hoping for a pulse and we may think we're feeling one. So how do we assess the TCP rhythm for capture? Well, this group of 3 leads, one strip, 3 leads, shows electrical capture. Very clearly we have the pacer stimulus, which is right here, we call it the spike. And then it's followed by a wide QRS, and most importantly, a wide T wave. When you see that QRS and T, you know that's a real QRS complex. So now we have electrical capture. We want to assess also for mechanical capture, so we check pulses. And as I said earlier, palpated pulses can be a little difficult if you're not real careful. Also, when you take an auscultated BP, you'll hear the pulse with your stethoscope, and that's very helpful. If the pulse matches the monitor, and you see each paced beat, you're hearing that pulse with the paced beat, then you know you have capture. The pulse ox can also be a help if it feels a pulse or detects a pulse when you have a paced beat, then you know you have capture. Some people now are starting to use capnography, which is very helpful. As the patient's perfusion improves, their CO2 should go up, and also the patient should look better. Once you've confirmed electrical capture on the ECG, you should start seeing signs of mechanical capture pretty quickly. If not, your patient is in PEA. Here's a rhythm being paced by a TCP. What do you think is going on here? I've indicated the pacer stimulus at the top with red arrows, so you'll see a spike under each of those red arrows, and they run through the entire strip. Notice that the first beat, and we'll stick with lead 2 here because it's easier to see the spikes in lead 2, but the first beat has classic capture. We have a wide QRS and a wide T, and that's a paced capture beat. Why do you think these beats here, from about the 3rd spike that I've marked through the rest of the strip, why do you think they are not producing one of those wide capture QRSs with a T wave? The reason is this beat here is the patient's own beat. It's an intrinsic beat, or called a native beat, and the pacemaker has placed its stimulus or its spike during the refractory period. So the heart's already busy making the patient's own native beat, and the pacer hit at a very inopportune time, and so now it can't make a QRS. Do you think this is failure to capture? Actually, it's failure to sense, because the TCP in this case has been put into a fixed mode. It's pacing or producing a pacer stimulus at a fixed rate, and it's not looking at or seeing the patient's own QRSs. So whenever the pacer stimulus lands on the refractory period of the patient's native beat, we don't see a paced beat. You'll see later on down the strip, the pacer spike lands out clear of that refractory period, and we get another captured beat. And in fact, we get 2 in a row. Let's take another look at that same strip, only now with more markers. I've left the red arrows for the pacer stimuli. The green arrows indicate the captured beats, the ones we looked at before that have a wide QRS and a wide T wave that indicate good capture by the pacemaker. There are 2 kind of orange beats here. That would be the second one I've marked, and then there's one over at the end here. They almost look like the yellow ones, but those orange beats are the native beats of the patient that are being conducted normally. They do have some ST and T wave changes, which will need to be addressed on a 12-lead ECG, but they have a fairly narrow QRS. All of these yellow arrows in the middle here indicate the patient's native beats being conducted with a conduction delay of some type, and I'm guessing probably right bundle branch block. It would be easy to tell if we had a 12-lead to tell what the conduction delay is. These are native beats. They're just wider than normal. Up in this lead 2, we see a fat little S wave, which makes me think right bundle branch block. And in lead V1, we see an upright wide complex. Doesn't look typical of right bundle, so like I said, we would need a 12-lead. But these are the patient's native beats. And again, like I said before, when we looked at the slide before, these pacer stimuli are landing right in those beats where it's just a very bad time for the heart to try to respond, and so it doesn't. There's no capture. This little blue one here, the blue arrow all by itself, I marked something kind of interesting. It's probably a fusion beat. And a fusion beat happens when a paced beat begins right when a normal beat is also beginning. I see a sign, a very small sign of maybe a spike right there, and so I'm assuming that this is a fusion beat. The pacemaker started to pace at the same time the patient began to have an intrinsic beat of their own, and the two kind of fused, and the resulting complex will usually look like a hybrid of the two. It's not clinically significant in that it's just another capture beat. One way to test for true capture, if you're still not sure, is to put the pacer into fixed mode. If a normal beat lands where the pace beat should be refractory, then the pacer is not capturing. In other words, if the pacer is working well and makes a QRS that's capturing, a normal beat can't appear in the refractory period of that paced beat. The heart's busy and it can't make another normal beat. When the normal beat lands in the area that should be refractory from the paced beat, which we have here, then that proves that was not a paced beat. There's no real capture, because otherwise this normal native beat couldn't have appeared right here in the so-called refractory period. So if the beats are stepping into each other's refractory periods, the pacer is not capturing. So what are some take-home points for this presentation? One is, if you want to avoid some of these TCP problems, get good electrode contact with the skin, get good electrode placement, and get rid of the debris and oils and hair that are on the skin. To assess for electrical capture, make sure that you have a QRS and a wide T wave. That's the ECG sign of good capture. Don't be afraid to raise the MA, often over 100 milliamps. Don't be afraid to touch the patient. Use the energy you need to get the patient paced. If you need to treat the patient for pain, do it. Normally use the demand mode if the patient has a slow underlying rhythm with pulses. That way the machine will see the patient's own beats and pace around them and not pace when it's not needed, and you won't have the spikes that appear on top of T waves in QRSs. To be sure you have capture, use the pulse ox, auscultated BP, and capnography to confirm. Here's some good references on that topic. The EMS 12 League blog has some really good articles on this topic. The problem of false capture is one, and using capnography to confirm capture with transcutaneous pacing is another. I'll get the links up here for you. And the Physio-Control website has a section on pacing artifact masquerading as capture. I hope you find this helpful.